It's the time for questions.
في أي أسئلة هنا؟
يعطيكم العافية دكتورز. question على giving glucose يمكن كنت بسأله من أيام السيجر بس دامنا الحين ممكن نسأل since we already talked about. So some reference prefer like giving thiamine before glucose, especially for seizure, for instance, or يعني. What is the cause and why not? Before glucose directly على طول في emergency setting.
In seizure situations?
In general, but specifically for seizure. They prefer it for alcoholics, but يعني in our يعني most of the cases with seizure patients.
So in alcoholic patients or in seizure patients, when you go back to your pathophysiology to the Krebs cycle, you need the thiamine to function for the Krebs cycle to work and to break down the glucose. So you should give the thiamine first, not the glucose.
Not to have hyperglycemia.
I don't get your question.
يعني we need thiamine to like metabolize the glucose.
To break down the glucose, yes.
Okay, great. So we give thiamine before glucose not to have hyperglycemia.
Yes. So you either give the thiamine first or you give them simultaneously if you're going to give simultaneously.
دكتورة انت you mean البيشنت اللي he came with hypoglycemia, right? ولا he came with decreased level of consciousness?
Like in general when we yes.
Alcoholic and seizure.
Yes.
And alcoholic decreased level of consciousness.
Yes.
So giving glucose will not cause hyperglycemia. It will not be utilized. It will not be breakdown. That's all. It's not related to the hyperglycemia. We're not causing DKA by giving glucose. It will not be utilized.
No, I think what she was saying is that you give the thiamine first so that the glucose does not cause hyperglycemia due to not breaking down.
So we take it to be stored يعني rather than يعني.
Yeah, so it will not be utilized. We are not causing hyperglycemia. We are supposed to cause hyperglycemia, but it will not be utilized. That's the issue.
Yes.
There is no benefit of giving dextrose. So he's not getting benefit by giving dextrose. Anyway, there is a lot of evidence against giving thiamine before dextrose now, and you can give dextrose whenever you want it. Regardless of the thiamine, you give it or not, even if he's alcoholic. But if you have the chance to give it, I mean, you don't wait until you get thiamine to give dextrose. If he's hypoglycemic, give dextrose, and if you have thiamine anytime, you can give it. So there is no evidence that's really affecting the management of the patient or causing post-call or whatever of the complication mentioned before. But it will not cause hyperglycemia. It will be useless dextrose that we give. That's all.
Thank you.
Wait.
Yes, my question goes to Dr. Omar. So I have two questions basically. The first one is, you said we can hold the vitamin K and we can give it in patients with high risk of bleeding. Who is that group of patients? The second question is, do we consider microscopic hematuria as a minor bleed or as a major bleed?
So for the first question, if it's one more time.
For example, in asymptomatic INR, we can give the vitamin.
The high risk of bleeding, you mean?
Yes, the high risk group.
So I mentioned simply if the patient is elderly, even in the guideline they didn't put the patient at risk of bleeding. But simply, if the patient, you think this patient will have a trauma, easily get traumatized like a pediatric patient who's playing around the whole day, you think this patient is at risk of trauma, you need to give him vitamin K. Patient is elderly who will develop intracranial hemorrhage, subdural hematoma regardless, even without trauma, those patients should take it. But this was not mentioned in the guideline. Nobody mentioned what are the high-risk patients. But you can put them, you can find them by looking around other articles to find who's at high risk. But in general, those that coming to my mind now, elderly, a patient with, you suspect that will have trauma, like the patient who's walking around all the time, the patient with special diseases, CP, and those patients that will get trauma all the time, those patients should get vitamin K.
And the other question is the microscopic hematuria. Do we consider it as a
so microscopic hematuria by definition is not a major bleeding. The only major bleeding that I know, I remember now, it's three: the joint, GI, and brain. This is only the major bleeding. All others considered as minors, unless it's gross hematuria.
So I would like you to answer this question from what you've learned today. Why do you think you need to do a glucocheck in a cardiac arrest patient? So, you remember when we said the H's and P's of the causes, correcting the causes of cardiac arrest, right? One of the H's was what? Hypoglycemia. So hypoglycemia can cause a decreased level. So hypoglycemia can cause a decreased level of consciousness, and if this patient is in a prolonged decreased level of consciousness, let's say he was sleeping at home and no one was around for a day or two, the patient will comatose and most probably arrest. So the reason of doing a glucocheck is to identify if he might be in a DKA, severe acidosis, which causes him to arrest. Either way, either it's a hypoglycemia or a hyperglycemia. Okay.
Okay, in DKA, what is our pH goal? Is it when يعني سؤال when do we start to give the patient subcutaneous insulin instead of IV insulin and make him to eat يعني meals, and at which target is our pH? ولا هل هو التارجت ولا لا؟ يعني.
So, and maybe the doctors will correct me, but your goal in the DKA is correcting the anion gap. Once you close the anion gap to normal, that's when you stop giving the infusions of insulin and then start giving him his normal insulin, overlapping the insulin and then starting him on his regular doses. So the goal is the anion gap. Correct the anion gap and then you stop.
So the best thing to follow is anion gap, not the pH. The pH will correct it maybe in the first day. So it doesn't need really to be followed. What needs to be followed is the anion gap.
How can non-compliance to medications causes hypoglycemia?
So let's say the patient is on oral hypoglycemics and he's non-compliant to medication, or let's say he's on insulin and medications. He did not take his insulin dose and he did not eat the whole day. So maybe non-compliance to medication will not cause hypoglycemia per se, but in another way around it might cause hypoglycemia. What you would suspect that a patient stopping his medications would go into hyperglycemia rather than hypoglycemia. But maybe in a non-direct way, I have no idea.
Thank you.
السلام عليكم. بس أول شيء أحب أنتهز الفرصة هذه أشكر جامعة الملك سعود، الله يعطيهم العافية. الملتقى جدا جدا رائع، وأتمنى صراحة يستمرون بمجهوداتهم هذه، الله يعطيهم العافية. سؤالي للدكتور عمر وبقية الدكاترة. From my practice, I saw a patient who has hemorrhagic stroke and myocardial infarction. يعني البيشنت هذا عنده INR high, but he has clots. So in these cases, how should we deal with this patient? Should we deal with the clot or deal with the hemorrhage?
So عشان to correct some of the concept, having intracranial hemorrhage doesn't mean your INR is high. So let's differentiate between the patient who's an anticoagulant for controlling INR and the patient with intracranial hemorrhage. So if you came with intracranial hemorrhage and that's happened, if you came with intracranial hemorrhage and MI at the same time, it can happen. It's one of the contraindications for thrombolytic and heparin, both. So once you have this, your aspirin is not contraindicated, by the way. You still can give aspirin for the patient, but the patient should go to, you are from National Guard, right? عشان كده ما تعرف thrombolytic احنا بنعرفها. So your patient should go to BCI. خلاص? This where the BCI are, and the heart is first. So your heart will go first, your BCI will go first, and then the management of intracranial hemorrhage will be later on, the second thing. So if you're having MI, like your patient, MI and intracranial hemorrhage, he will go to BCI first, did his stent, then he will go to OR to manage his intracranial hemorrhage, if it's operatable. And if you need to reverse it, like INR high, you need to hold on until you finish your BCI. So you will not manage this until you finish your BCI first, and then you manage your INR if he's on warfarin, like patient on warfarin or something like that. I hope you will not face this in the real life. Yes, please.
We give a patient vitamin K and factors like factor 7.
So if you're talking about thrombocytopenia, and actually it's a wide term. So if you're talking about like TTB or ITB, those patients should not receive reversal agent. Those patients we should manage.
It's normal PT usually.
Even if it's abnormal, they should not receive a reversal agent. You should manage the main disease. You should manage the autoimmune condition or the sepsis, like the patient if he's having DIC, like you said. You should manage the main condition. Treating patient with fresh frozen plasma doesn't improve the patient outcome. Didn't change anything, didn't reduce the risk of bleeding, it didn't do anything for the patient. So if we are saying thrombocytopenia, it's a wide term, and I will not say it alone, but if you are talking like specific type of thrombocytopenia, like ITB or TTB, those patients should not receive any reversal agent. And if we're talking about DIC, if you have a DIC, you are as good as dead. Actually, the mortality is around 85%. But again, reversal agent was not proven. Factor 7, they have a lot of study. I don't remember the last one, it was beneficial or not, but they have a lot of study on factor 7, and I don't think it showed any benefit. Until the last study, I don't remember that finding any benefit. So any reversal agent will be useless. You need to treat the underlying condition, either sepsis, or you take him for a spilectomy if you're talking about ITB or TTB. So, or you give immunoglobulin, depending on the disease. So treat the main condition.
If in a cardiac arrest situation, الحين we said that we start by checking the pulse. Like, what if مثلا the case was that the patient was found unresponsive on the ground, there is no one to give history, and we don't know when did this start, and when did the patient been unresponsive. So do we always start CPR for our patient؟ يعني ممكن يكون في احتمالية إنه ميت له ساعتين. يعني أنا على أي أساس أعرف مثلا يعني. I'll check the pulse, I'll do anything بس يعني.
So this is a good question because it always comes. Either on the floor or either the family bring the patient to you, they were saying, we don't know when the last time he was awake. He was sleeping in his room, or he was in his room and we found him. We don't know how long this has been happening. So as a physician, initially you start the CPR, no matter what. There's no pulse, you start the CPR. Until when? Until you put the patient on a monitor. If you do the CPR for 2 or 3 cycles and the initial rhythm on the monitor is a flat line, you're sure he's 100% dead, then you stop. You stop. That's the end of the story. But if you put the patient on a monitor and he has some cardiac activity, you resume the CPR for at least 20-30 minutes, and then, as we said, it's a case-by-case scenario depending on the physician's judgment. So if you don't have a clear history, and most likely he's been there for a long time, and your initial reading on the monitor was a flat line or PEA, and then you stop after a couple of cycles.
So initially start every unresponsive, like arrested patient, you have to do CPR for at least 20-30 minutes.
Not 20-30 minutes until you see your monitor. Every 2 minutes you're checking your monitor. If you did, let's say, 2 cycles or 3 cycles and your monitor is a flat line, yes, you stop. Thank you.
Last question. دكتور فهد، في الالترد منتل ستاتس شويه شتتنا، بس ايش الاشياء المهمه ان في patient came with the altered mental status ممكن to exclude first؟ لانه انت قلت شرحت كل المواضيع وشرحت each investigation but how to بس
اتوقع انه يمكن في نيمونكس الناس يتكلمون عنها، انه how to remember the causes. مثل في واحده مشهوره ل AIOU tips مثلا، مشهوره مره اذا كنت سمعتوا عنها. تجمع ال انا ما حطيتها لانه كل واحد له نمونك على كيفه، بس هذه مشهوره، هذه AIOU tips. لو تبحث في جوجل راح تطلع لك كل واحده منهم وش يقابلها. لكن اتوقع انه يمكن the 3 emergency causes that you need to know، ولا ممكن نقول 4 كارديك الريست هو الواحد، لكن الثلاثه يمكن الهايبوغليسيميا اتوقع انه مهم مره، لانه الهايبوغليسيميا is a time sensitive management، ويمكن ويكون معه في نفس الفكره، في نفس يعني نفس الفكره الهايبوفوليميا والهايبوكسيميا. هذول الثلاث اشياء هم اللي يمكن مره time sensitive انه to manage them. الاشياء الثانيه they can wait a few minutes, they can wait until you figure it out. لكن هذول الاشياء اتوقع انه مره تايم سنسيتيف. ومع البراكتس ترى الاشياء هذه تمر عليك كثير لدرجه انه خلاص تحفظهم يعني. لانه كل مره يجي بيشنت الترد راح تمشي فيهم، وكل واحد له سيستم. بعض الناس يتكلم يقول لا انا بمشي على الثيم، هل هو انفكشوس، هل هو توكسيك كوز، هل هو فانكشنال، هل هو يمشي على الثيم. في ناس عنده نمونيك يمشي عليها. فاتوقع انه كل واحد له he has to develop his own يعني approach so to speak.
بعدين ستارت.
اي يمكن هذول هم الاشياء اللي لازم هذول من البدايه تصير عارف عنهم يعني. هذول هم الاشياء اللي ما تحمل تاخر يعني. الاشياء الثانيه ممكن انه ينتظر المريض شوي لانك you figure it out.
السلام عليكم. Now it's time for a break. We'll make it shorter because most of you look tired. So it will be 10 minutes, 9 minutes, and we will be here at 2:50. So please come at time so we can leave. It will be 2 talks after the break, so please be careful to come early. Thank you. السلام عليكم. السلام عليكم. بنبدأ الآن مع دكتور محمد.
السلام عليكم.